Welcome, everybody. We are so thrilled to have you joining us today for this presentation, the first global presentation, actually, on the modified Delphi process that the International SCN8A Alliance hosted to build and gather consensus around managing, treating, and caring for those living with SCN8A. This was a massive effort. We're just really thrilled to be here with you. Scott, what's your thoughts on why this happened, how this happened?
First of all, I'm glad it's over. No offense, no offense to all the people we worked with, but holy cow, it was a lot of work. Mostly credit to obviously you guys and your team at getting it done, but to find the people to do it and all the work we put into it, it's really great to see it coming to an end and to present it to everyone today. Super useful resource for something that's such a rare disorder where individual providers may have never seen it, or if they have seen it at all, they've seen one instance or two instances. Having a document like this, super helpful to kind of guide how we go about diagnosis, therapy, thinking about all the comorbid conditions. I think it's going to be really valuable for providers, hopefully very valuable for families to provide to their providers. I think it's a really essential step.
Yeah, it's really powerful. And really it was done because we knew that that this was one of the biggest gaps for both families and clinicians, really thinking, how do we know what to do when we get an SCN8A diagnosis?
Yep.
So it really is, it was a product of wanting to make sure that we can do the best we possibly can for all of those who get diagnosed. So pardon my delay, but I'm putting into the chat here, this is our global translator. So for anyone joining us that wants to see today's meeting translated into more than 50 different languages, please just click that link. It will open up a new window and you choose your language and you can follow along and listen in as we're talking today. So we'll drop that in periodically just to make sure that everyone has access. But if you have any questions, please just shoot a message into the chat and we'll try to help you troubleshoot. Excellent. All right. So Charles, can we go to the next slide, please? In terms of what to expect today, this was, as Scott alluded to, an incredibly intensive process, and we're so incredibly grateful to everybody that was a part of it. You'll see at the end, we acknowledge everyone who played a role here, large number of clinicians from around the world, more than 30 clinicians from 16 countries and 5 continents and 13 families as well. So this is a lot of time and effort that went into this. And so that's why you see today in our agenda that we're really going to be covering a lot of ground, and you'll be hearing from leaders and families who were involved in this process on 5 particular areas. And these are statements from these people who were involved in the consensus process. And we're going to be talking about first, hearing about the process. How did we do this? What did it entail? And that's with Elaine Worrell, who is an expert in modified Delphis. We're going to be hearing about the comorbidities. We're going to hear about the phenotypes, treatment, clinical features, and more. So without further ado, let's take it away and hear from Elaine.
Well, hello, I'm Elaine Worrell, and I am a pediatric epileptologist from Mayo Clinic, and was working very hard with the SCN8A Alliance on this project. So the modified Delphi process is a process that we use for consensus building if there is not high quality evidence in the literature. And so it can be very helpful for conditions like SCN8A, which are quite rare. So I'll just walk you through the process. So we started with our core panel of 13 clinicians and 6 families, and we divided that core panel into 3 groups, each tasked with reviewing the literature and coming up with specific potential questions for the first survey. And the 3 groups were on diagnosis and phenotype, treatments, and prognosis and clinical features. And they were asked to answer those questions, and if they disagreed with any of the statements that we had made, to provide feedback on that. The leadership team then reviewed each questionnaire and identified where we had consensus and also areas where we did not have consensus, and then reviewed those comments from the panelists to see if we could reword those questions to potentially gain consensus. And so that process was repeated twice more for a total of 3 rounds. Following that, the leadership team then prepared a draft manuscript and sent that back to our review panelists for further input, modified that as needed, and that was our final consensus report. And for our reviewers, for the clinicians, we asked them how many years they had been involved in either treating or studying SCN8A, and you can see for the vast majority that was more than 6 years. We also asked how many patients had they treated with SCN8A, and again, you can see for the majority that's more than 4 patients. For the caregivers, they were asked to indicate the age of their loved one with SCN8A, and they were also asked to indicate, besides their loved one, how many other cases of SCN8A were they familiar with. And you can see that the caregivers were familiar with certainly more than 6 other cases in the vast majority. So understanding consensus level based on the level of agreement that we obtain. So strong consensus were if more than 80% of panelists strongly or fully agreed with the statement. Moderate consensus was if 80% or more fully or partially agreed and less than 10% disagreed. And modest consensus was if 67% or more fully or partially agreed and less than 10% disagreed. And so we reported the level of consensus for each statement in the manuscript. And in this summary today, we're going to report consensuses of modest or greater. For each question, it was possible that our panelists maybe didn't have an opinion, and so they were asked to comment, no comment, or don't know responses, and we excluded those from analysis. However, we did want to ensure that we had an adequate number of people who responded appropriately to each question. And so if we had a total responder rate of less than 50%, we did not consider that consensus, so we excluded that. It's important to understand the limitations of the modified Delphi process. So this is an excellent process to try and build consensus where there's limited evidence in the literature, but it is not equivalent to medical advice. So certainly I think it's appropriate to share the reports from this consensus with your loved one's medical providers. And hopefully this will help us work together to try and gain a higher level of expertise and potentially even consideration of randomized clinical trials, randomized placebo-controlled trials to look at therapies that can better treat SCN8A.
Yeah, so as you can hear, this was an incredibly rigorous process, and we're so incredibly grateful to Elaine Worrell for helping guide us through this. She has done this before. She did this with Dravet twice now, and so we just really could not have done this without her. Scott, what are your thoughts?
Yeah, I think Elaine pointed out a few things that I think we really want people to take home. Number one, this is not medical advice. This is the best consensus we can come to, gathering a large group of people who, have experience in this condition. I think what's one of the important things, if you looked at those slides and you looked at what that experience was, the overwhelming majority of the people who participated had seen maybe 4 to 5 kids, at least, with the disorder, right? But we'll be talking in a minute about the phenotypes, and there's 5 phenotypes that we agreed upon. So really, if you think about that, there's that number of phenotypes, and some people had only seen that many patients in their career. It's very difficult to create consensus for everything. And so that's what I think for some people will notice as we go through. We reach consensus on an awful lot of things, but there are an awful lot of things we did not reach consensus on. Very hard to reach consensus when there's very little literature on a subject and there's very little experience for the subject. But that's still an important outcome of this process, because now it has identified all of these gaps that we need to begin addressing. And these kinds of processes are really a foundational process to begin now looking at all these things that we recognize we do not fully understand. And when there's another consensus in a few more years, you're going to see hopefully a lot more consensus. And these build over time. You can see that with the Dravet consensus over time, how it has changed, and we've gotten more and more agreement over more and more time. Likewise, things like this hopefully bring attention for people of what these disorders look like. So maybe there'll be more people understood to have these conditions, then there will be more experience with this condition, then there will be more consensus. So I think you'll see that it's going to evolve. I hope you see the importance of this. And then I hope everyone gathered from Elaine's kind of overview of the process, like how rigorous this was. You know, it's not just asking a couple people to give me your opinion. I mean, it starts with a very in-depth literature review of basically everything we could find out there on the subject. From that literature review, we tried to create areas that we thought there could be consensus because there's at least some literature or an experience in it. And then when we didn't reach consensus or it wasn't clear we were almost there, we tried to rephrase it to see if rephrasing it got us there. And if it didn't, it didn't. And we move on. So a very good process that I think gives us some very good information that I think will be very helpful to everyone along the way. Did you have anything else to add before we move on to the next sections?
No, I think you covered a lot of ground there. So no,
okay.
That's great.
Well, in this next section, we're going to be going over some of the consensus that we were able to reach on things such as timing of diagnosis, specifically early diagnosis, EEG and MRI patterns that can be seen with the SCN8A related disorders, the importance of genetic testing and how counsel for that testing. And so to present this section, we have Dr. Mitsuhiro Kato. So let's go ahead and play that.
Hi, I'm Dr. Mitsuhiro Kato, working on pediatric neurology, particularly epilepsy and genetics. I'm living in Tokyo. I'm talking about SCN8A early diagnosis. So early diagnosis of SCN8A is important for long-term seizure outcomes and potentially developmental outcomes. SCN8A-related disorders are heterogeneous conditions with varying clinical presentations, ranging from severe developmental epileptic encephalopathy to neurodevelopmental delay without epilepsy. Diagnosis of SCN8A-related disorders is made via genetic testing using gene panels or whole exome sequencing. Genetic testing is suggested in epilepsy and in neurodevelopmental delay of the unknown cause without epilepsy. Broad genetic testing is strongly recommended in all cases of drug-resistant epilepsy, without clear structural cause in particular. Even in SCN8A-related severe DEE, initial EEG may be normal, but typically becomes abnormal throughout the course of epilepsy, irrespective of the severity or type of epilepsy. Some noted EEGs often show much focal spikes and background slowing. The results of MRI vary by phenotypes. Initial MRIs are frequently normal across all phenotypes. However, MRIs may become abnormal, often demonstrating atrophy in severe DEE patients, while MRIs frequently remain normal in other phenotypes.
Excellent. Yeah. So I think it's interesting. We're definitely seeing a trend in earlier diagnosis, in particular in the last year, I would say, well, for a while, it's been with the severe cases. Those are the cases that tend to get diagnosed earlier. But even getting more diagnosed folks of people who don't necessarily have epilepsy or are on getting tested via autism panels and other kinds of testing. So we know that it's really important to get tested early because it can help with more targeted treatment and access to kinds of care and therapies. And we think that there's so many more people living with SCN8A than we have found so far. There's a recent article, Scott, I don't know if you saw this one, that said that SCN8A is likely, the incidence is even higher than Dravet with some newer calculations on incidence. So we know there's a lot more folks out there. And, we know Dr. Kato had shared that even genetic testing in Japan is very hard to get. So this is something that's emerging around the world about where is there access, who can get it. And this, this consensus, hopefully once somebody does get diagnosed, will give them more concrete information to treat those families when they see when they get diagnosed. So anything else you want to say about diagnosis?
Well, yeah,
MRI,
I think from that,
EEG, Scott?
yeah, I think from that section, a few things. One, we weren't so much even asking the genetic questions specifically to SCN8A, so much as asking, like, in what circumstances might it be worthwhile to do that testing. And I think that's just useful for identifying people with the condition, because there's certain populations that deserve to have the testing done, number one. I think the other thing you pointed out, which you'll see throughout the presentations, is that consensus was more often reached in the severe DEE phenotype, which is not surprising, because that is the phenotype that is, most people have the most experience with. Because again, it probably goes back to genetic testing. The more severe the case is, the more likely it would have received genetic testing. And so you're going to have a larger population for that. Another key feature that it pointed out that I think is important is that oftentimes the EEG is normal, at least at some point, especially early on in the course of all of the phenotypes, really. So a normal EEG does certainly not rule out SCN8A. Same with the point of the MRI. A normal MRI doesn't necessarily rule in or out SCN8A. So just important findings that I think kind of help guide how you evaluate a patient moving forward.
Yeah, absolutely. Yeah, I think we're going to learn so much probably in the next couple of years as well, too. I think it's really, we're constantly learning more. So, okay, next we're going to move on to looking a little bit more about the diversity and presentation in SCN8A. So while Elena Gardella and some others had published about the range of phenotypes that exist in SCN8A, it was really important that we get that consensus from a diverse group of clinicians and families around the world to help us really build agreement that that is what SCN8A looks like, that diversity of SCN8A. And while we know that there's more than probably 5 phenotypes that exist, there's not consensus on those yet, but we're really excited that we have this to start with. So here's Elena Gardella talking about our work in that.
Hello, everybody. It's a great pleasure being here. I'm Elena Gardella. I'm a neurologist and clinical neurophysiologist, and I dedicated the last 12 years of my work to the research and the phenotype and the clinical manifestation of SCN8A related disorders. It was a great pleasure to me to take part of the Delphi consensus as chairing the research group on the definition of the phenotypes, and having the pleasure to collect the opinion of colleagues. I realized that actually there is a consensus about the presence of at least 5 different phenotypes. And for phenotypes, we intend clinical presentation of disease, clinical aspects, which are quite different and distinguishable from each other, and reflect, different, in needing the needs to be addressed. We have the severe developmental epileptic encephalopathy, which is the most severe phenotype for SCN8A. We have a mild, moderate developmental and epileptic encephalopathy, where both epilepsy and development are less. A self-limiting infantile epilepsy, which is actually as actually a very benign prognosis. And on the other side, we have formal generalized epilepsy and even cases without epilepsy at all. The key feature for these phenotypes actually are focused on the determination of the age, the seizure onset, and on the other side, the age of onset of developmental delay. The seizure types and all the other clinical features which are not related to epilepsy, but as contribute to the severity of the phenotype as well. Determining when children and patients can reach seizure freedom, if they do, and having also an overview of the prognosis for the no-seizure manifestation and phenotypes. So, what is the difference in the 5 phenotypes that we mentioned in terms of these key characteristics? What we know is that the severe phenotype of an earlier age at onset of epilepsy and generally also all the other clinical manifestation. There is a very early age at onset of seizure, and almost simultaneously in most of the cases before the age of 6 months, it can be evident some degrees of developmental delay. And achieving seizure freedom is quite difficult in this phenotype. For the mild, moderate epilepsy phenotype, we are an age at onset which is slightly higher. We have also the developmental delay starts in most of the cases later in life, sometimes after epilepsy onset, and the clinical feature associated with that are less pronounced and less invalidating for the subjects. Seizure freedom is possible in these cases. It's still an heterogeneous subgroup, but actually we can aim to achieve seizure freedom in this condition. And for the no-seizure manifestation, actually, is, as far as we know so far, there is a limited possibility to modulate, but still hope. Regarding to self-limiting infantile epilepsy, this is a very benign phenotype. Unfortunately, there is a little group, but actually the age of onset is still of epilepsy is still quite early, but the outcome is very good in terms of seizure control, in terms of cognitive and developmental outcome, and the comorbidities. We have the 4th phenotype is comprised generalized epilepsy. This is also a little group with very benign outcome normally in terms of epilepsy control. Unfortunately, the clinical features are not severe, but are difficult to control as well, and mainly consisting of mild cognitive impairment or autism spectrum disorder or movement disorder. The very last group, which is probably an underestimate, but is a little one, is about the clinical manifestation which are not associated with epilepsy. In this group, epilepsy doesn't appear. We just say either intellectual disability or movement disorder, or a combination of the two in some cases. We do not have, to our knowledge, we do not have that much room for modulating the outcome of this group, because we are not aware of treatment really effective on this group. This probably will be promising for the future. SCN8A is very important to regulating that, but a variant, an alteration in the structure of the protein which is encoded for SCN8A can give rise either to an excess of function of this channel, which is called gain of function, or for other mutation, for other variants, the effect can be the opposite. The channel can work less than expected, and a loss of function. So that means that we are dealing with imbalance of the autosodium, which are possibly opposite. That means also that we need to be able to distinguish the gene finding that leading to a gain of function for the one that related to the loss of function, because also the treatment, as in is, I mean, is logically is intuitive. The treatment is opposite. For the gene file that giving rise to the gain of function, we need to block this excess of activity. For gene defects which are actually giving rise to the loss of function, we need to avoid to block them much and probably find strategies to promote or increase the activity of these genes. We know now that actually these first three phenotypes that we are characterize, which are the severe DE, the mild moderate DE, and the self-limiting infantile epilepsy, all these three phenotypes are related to variant SCN8A, which are giving rise to the gain of function. And this has an important implication for the treatment of this phenotype, which will be discussed later in the next talk. To the opposite, the generalized epilepsy and all the phenotype without epilepsy are in almost all the cases related to variant in SCN8A that give rise to a loss of function. In these cases, sodium channel blockers, treatment that block the activity of this the sodium channel, has to be avoided.
All right, so I think what people need to take from that section right there, first of all, is that section was like essential to the success of the entire program. Because when we started the process, we started the consensus survey, we first had to agree as a group that there were either a presentation or a set of presentations of SCN8A. If we could not reach consensus on that, pretty much the rest of it was going to be a waste of time, because we wouldn't be able to associate any of the prognosis over time, the seizure types over time, the comorbidities over time, because we would have nowhere to start. So that was really big, that we were able to agree that those phenotypes exist, recognizing there are likely others. We will likely have some others characterized over time, but those are the ones. Some real key features there that I think are useful for maybe the person with either a new diagnosis of SCN8A, or at least a genetic test that has SCN8 on it and their provider is unsure whether they have it or not. That gives a decent core consensus of how the different versions will present that could be used to hopefully help solidify or get you towards that end diagnosis. I think the other thing that I was happy to see come from that was some consensus on things like whether seizure freedom could be achieved. And while we reach consensus that, you know what, it doesn't happen in severe DEE, and the others, we recognize that sometimes it does. So in a person with mild or moderate DEE phenotype, sometimes it does. And I think that's helpful to have that consensus for a person that maybe goes and is like, oh, you've got, SCN8A, and at least in the knowledge of the person caring for them, this is an epileptic encephalopathy, and seizure control should not be our goal in treatment. Well, maybe it should. Consensus suggests that sometimes it happens, so it should be. Frankly, it should be our goal in severe DEE too. We got to keep working at that, but I think that really gives a good framework for people to approach the diagnosis and therapy of the condition and what to expect.
Yeah, no, I think the phenotypes are so important. And I think one of the things that I really wanted to make sure that we emphasize is that we fully understand that this is not fully representative of the existence of different forms of SCN8A, right? So we know things like a more severe loss of function, or onset of epilepsy at 27. There are many different kinds of presentations of epilepsy, of SCN8A. And I think as time goes on, we will begin to expand what those phenotypes and presentations are, because the diversity is going to continue to increase. And the more we see of these different groups, the more we'll learn, and we'll continue to ask these questions so that we can have that consensus ongoing. So that's all I wanted to add to that section. Yeah.
Yeah, no, I think that's a good point. That's kind of like I pointed out in the beginning, right? We have to reach consensus, and to reach consensus, there has to be at least a decent amount of experience. And we know there's these core experiences, and then there's these areas in between. We're not going to probably reach consensus to the areas in between that overlap with each other, but you have to start with the cores, really identify the gaps, and then address them going forward. And what will be the next version? Okay, well, the next section is going to look at treatment. All right, and that's obviously super important. And we wanted to look at treatment now that we've agreed on the phenotypes that are present. How is the treatment impacted by understanding the phenotype, or maybe understanding the function of the gene itself? So a lot of unknowns, of course, remain with regards to the vast majority, the vast treatments that we have, but we were able to reach consensus on certain treatments that we definitely think should rise to the top. So to highlight that, let's go to Mark Fitzgerald, who is going to cover the treatment section for us.
My name is Mark Fitzgerald. I'm an epileptologist and the medical director of the Epilepsy Neurogenetics Initiative at the Children's Hospital of Philadelphia. I'm here presenting today in my role as the chair of the treatment subgroup of the SCN8A Consensus Guidelines Committee. After reviewing the available data on medication effectiveness in SCN8A related epilepsies, our team arrived at consensus for several treatment recommendations, as you will see highlighted in the coming section. We focused on the optimal first-line treatment of seizures and medications for which we need to be cautious of, and we've structured that analysis by both phenotype and function. We've also included some supplementary information here based on data from the Danish Center and the International SCN8A registry. And then we'll branch off into talking about consensus on managing multiple seizure medications and on other treatment options for SCN8A-related epilepsies. For those children with the gain of function phenotypes, that is severe DEE, mild to moderate DEE, and the self-limited epilepsies, the optimal medications in our analysis included oxcarbazepine and carbamazepine, both of which block sodium channels. While there are multiple additional medications that have a similar mechanism of action and also block sodium channels, our group was not able to arrive at consensus for these treatments based on the available data in the literature. However, as you will see from some of the supplementary data in the next few slides, there are alternative anti-seizure medication options worth consideration for these individuals with these phenotypes. We also arrived at a consensus to recommend against the use of levetiracetam in children with gain-of-function phenotypes, as there is literature data indicating that levetiracetam is less effective and in many instances may make seizures worse in some individuals with these gain-of-function phenotypes. For those children with the loss-of-function phenotypes, the optimal medications from our working group included valproic acid, ethosuximide, and lamotrigine. We recommended against the use of any sodium channel blocking medications in these individuals, as it would be expected that this class of medication would worsen seizures rather than help. In arriving at these consensus treatment recommendations, we performed a comprehensive review of the published literature. This slide encapsulates data from the Danish SCN8A registry. To the left of this graph are individuals with a gain-of-function SCN8A variant, while to the right are individuals with a loss-of-function variants. The shades of blue in the bar graphs represent individuals with either seizure resolution or seizure reduction when taking a particular medication. The yellow bars indicate no effect from that medication, and the dark gold bars indicate worsening of seizures with that medication. The drug abbreviations are listed in the center of the graph. As you can see, the medications whose abbreviations are listed in color represent sodium channel blockers, which have a positive impact on individuals with gain-of-function variants, by and large. While these medications typically have no effect or worsen seizures when used in individuals with loss-of-function variants. This slide contains data from the International SCN8A registry. On the left, the graph depicts both current anti-seizure medications and anti-seizure medications that were weaned off in those patients. And to the right, you'll see the caregiver assessment of both the best and worst anti-seizure medications listed in those blue bars. As you can see, levetiracetam is the medication on the left that is most commonly weaned off in favor of another treatment. And it is also the medication on the right that is most commonly rated as the worst anti-seizure medication for seizure control based on caregiver assessments. Medications of the sodium channel blocking class, such as oxcarbazepine, on the other hand, are commonly used by patients in the registry and are most commonly related as the best medications, according to the caregiver assessments. Importantly, we also considered the impact of multiple medications on the quality of life of individuals with SCN8A related epilepsy. We thought about this as equally important to the patient journey as the pure efficacy of these medications in treating seizures. And we really sought to recommend some guidelines about how to manage medications in individuals with hard-to-treat epilepsy related to their SCN8A variants. We arrived at a few consensus recommendations, as you can see on this slide. First, the maximum number of medications recommended for concurrent use was 3 to 4. We recognize, of course, that this number may be fewer depending on the individual's clinical phenotype and either the number or the type of seizures that an individual is experiencing. Second, the seizure type has a high impact on the choice to add a medication. We reached consensus on the fact that poorly controlled tonic-clonic seizures and prolonged seizures consistent with status epilepticus are the most important factors when choosing to add another medication to the individual's treatment recommendation. Of course, if an approved SCN8A specific therapy were available for general use in the future, our group felt like this would also warrant the addition of this specific treatment to an individual's medication regimen. Third, we recommend several considerations when determining which medications to remove when modifying therapies. Most importantly, we reached consensus regarding the fact that medications with limited efficacy should be targeted for removal. Also, medications with side effects in excess of their benefit to seizure control should also be considered for removal from the medication regimen. Additionally, medications with duplicative mechanisms of action should be considered for removal, in addition to those medications which are having a negative impact on developmental progress or that are leading to additional caregiver concerns. And finally, we reviewed a variety of other non-pharmacological treatments for children with SCN8A-related epilepsy. First, I would like to say that it is important for clinicians to be aware of the potential for children in the severe DEE phenotype to develop infantile spasms. There are well-established treatment protocols that are applicable for individuals with infantile spasms. And we had consensus on the fact that individuals with SCN8A who have infantile spasms should also be treated in accord with these existing protocols. Regarding the issue of resective epilepsy surgery, despite the relative lack of published data on this particular treatment, as applies to individuals with SCN8A related epilepsy, we arrived at a high level of consensus on the lack of utility of this particular treatment approach. This was largely due to the fact that we anticipate that SCN8A variants are likely to impact all brain networks, rather than a select few that would be amenable to a surgical treatment approach. Regarding the ketogenic diet, we arrived at a modest consensus in favor of its effectiveness, and we recommended its consideration for individuals with SCN8A related epilepsy who have hard to treat seizures. And lastly, we considered cannabidiol and vagal nerve stimulators, but were unable to arrive at consensus on the utility of either for treating individuals with SCN related epilepsy, largely on the basis of insufficient data on the literature, though we acknowledge that these individual treatments can be considered on a case-by-case basis.
Yeah, I love this section. I think Mark did an incredible job, and I think there's so much ground covered here in terms of what we know. I think it's so incredibly valuable to have this on really outlining how phenotype and function influence treatment, clinical features, prognosis, all of these kinds of things. And I think, some of the things that stood out for me particularly are that, without specific treatments targeting SCN8A, all we can do is chase the seizures, right? And try to balance with quality of life and, managing those elements. So, and I think it was really, really powerful that we got consensus about how important it is to recognize the importance of quality of life in things like limiting the number of anti-seizure medications that, we talked with somebody who had a 1-year-old that was on 6 different ASMs. And it was like, that's not going to help. It's just not going to help at that point. And I can't even tell you the number of families that come at us with saying, oh, my child has spasms, but they say it's SCN8A, so we should use a sodium channel blocker. It's like, no, you gotta. So, having this consensus is so powerful because we can put it in the hands of clinicians and we can put it in the hands of families who can then take it to their clinicians and say, see, we need to follow this. We have guidance. Yeah, what do you think, Scott? What stood out for you?
First thing I think is that this sure would have been useful a little over a decade ago when I saw my first child with loss of function. And, made the assumption that, well, SCN8A needs sodium channel drugs. And so I found out the hard way. That was not the correct answer. Nonetheless, doing very well now that I switched to the correct medicine. So, maybe we can skip that step in the future with a document like this. The other thing I want to point out is kind of what I've said before. These are areas we reached consensus on. There are many areas we did not reach consensus on. As a person who believes very strongly in the use of epilepsy surgery, I will point out that what we said was that resective surgery should not be considered in SCN8A, because actually removing a section of the brain is not going to change the fact that the SCN8A channel is varied throughout the brain. But we weren't able to reach consensus on things like neuromodulation or disconnective procedures such as callosotomies and things of that nature. So there may be places for those things. And again, that just identifies a knowledge gap that we need to try to assess more over time so that maybe we reach more consensus next time we do this process. But again, super useful. Again, my experience a decade ago just shows how a document like this could be really useful right now, so that you don't have to figure this out the old trial and error way, if at all possible. So our next section was a toughie. and a tough one because this was really looking at the variety of comorbid conditions across the 5 phenotypes. And again, to start that, you needed some literature. And as you can imagine, the literature on any individual comorbid condition with SCN8A is a bit light. You have some movement disorder literature. We might have been lucky enough to have some GI literature here and there. But you know, the group of comorbid issues we collected from, you know, all the patients, things from the registry saying these are all the things going on, super difficult to find much literature on that, since most papers are really focused on the seizures themselves, the epilepsy, and not the comorbid conditions. So this was an exciting feature, or exciting a piece of the program to look through it. I think what you'll see, again, as I said before, there's a lot more consensus with regards to these other features with the severe DEE, lesser with some of the other phenotypes, again, just because of the overall experience with that phenotype across the panel. But nonetheless, let's go to this section. We've got Dr. Christelle Ashkar to present this to us.
Hi, my name is Christelle Ashkar. I'm an attending in epilepsy and neurogenetics at Boston Children's Hospital. And I have had the wonderful pleasure of working with the SCN8A Alliance on this much needed project to look into areas of consensus in the management, diagnosis, and expectations in SCN8A. And I think that the Alliance has done a fantastic job pulling all of the specialists and these informations together. I will be talking about the clinical features associated with SCN8A. In addition to what has been discussed before in terms of epilepsy and seizures, meaning that these were 17 areas that were found across all 5 phenotypes, and there were 5 of them that were quite common clinical features across all 5 phenotypes, and we will go through more details. But in addition to looking at those particular features, the data was supplemented by information retrospectively collected regarding those clinical features, whether they are present or absent in the subgroup of patients who have gain of function variants and the other subgroup of patients who have loss of function variants. Finally, I will be reviewing our consensus on the prognosis for the epilepsy and the development, depending on the phenotype. The 17 clinical features here are divided under those 3 rubrics. The first one is really the neurological features, and these have featured fine and gross motor delays, different types of movement disorders, tone abnormalities, mainly hypotonia, cortical blindness or cortical visual impairment, autonomic abnormalities, sleep disturbances, and increased SUDEP risk. Under the rubric of development, the main clinical features were communication delays, intellectual disability, behavioral, emotional dysregulation, and more formal autism spectrum disorder. Slightly outside of the neurological realm and the developmental realm, looking at the rest of the organ systems, there were additional clinical features that were found to be and believed to be present in several of the phenotypes, and these included orthopedic problems, gastrointestinal or GI abnormalities, feeding difficulties, as well as respiratory pulmonary issues. A couple of highlights that I'd like to add here that are quite important from those findings is that the highest consensus that was found, and also backed by experience, was in the area of the severe DEE phenotype. It is also important to highlight that the highest consensus occurred in the area of severe DEE, where the respondents believed that all 17 clinical features occurred, and 15 of those features occurred in a very severe form. There was a large consensus that in the severe DEE, none of these features are expected to improve or resolve. There were 5 most frequently occurring clinical features across all 5 phenotypes that were agreed upon, and these included communication, fine motor skills, intellectual disability, as well as sleep and behavioral dysregulation. What we are looking at here is the percentage of respondents who believe that each of these clinical features occurs in at least half of the time in each of the specific phenotype. So going through each phenotype and giving some examples, you can see that in severe developmental epileptic encephalopathy, there is a rather large consensus where pretty much all involved respondents said that there are speech disturbances, fine motor skills, intellectual disability, and sleep disturbances. Behavioral challenges was still commonly agreed upon, although not as much as the other features. Moving to the phenotype of self-limited familial or non-familial infantile epilepsy, you can see that there is definitely fewer respondents comparatively to the severe DEE. This really leads us to learn that we need a lot more research in these particular areas. To go to another example, which is the neurodevelopmental disorders with epilepsy, one of the 5 phenotypes. Of course, all 5 areas are present, but you can also see that there were less respondents that actually reported that they believe it occurs in at least half of the time in that particular specific phenotype. And then I think it is important to look at the neurodevelopmental disorders without epilepsy, where there is more or less of a consensus in the areas of behavioral challenges, speech, fine motor skills, and intellectual disability, but not so much in the area of sleep disturbances. These are also features that are not very well reported in the literature. And so I think this is really showing us that while we do have consensus in some of the phenotypes, we really still have some work to do in the others. In addition to the consensus findings, those 17 areas were looked at in the 2 subgroups of patients with SCN8A, the gain of function and the loss of function subgroup. As you can see, seizures was found to be very common in the gain of function patients, but also hypotonia, sleep difficulties, GI difficulties, movement disorders, feeding problems, and the same applies really to the loss of function SCN8A, where several of these 17 clinical features were also found. Delayed speech was very common, as well as different forms of intellectual disability, developmental delay, autism spectrum disorder, behavioral abnormalities, even movement disorders, which is less represented here than in the gain of function SCN8A. And finally, we looked into what we believe the prognosis for either the epilepsy or the development is for all of these subtypes or subphenotypes of SCN8A. And what we're showing here really is the degree of or the strength of the consensus that that was found from all of the respondents. And to go through it one by one, when we talk about the seizures or the epilepsy itself, under severe DEE, there were really no respondents that said that there was going to be significant improvements, but there were the rest of the respondents were split between the possibility of modest improvement, some limited change, modest deterioration, or severe deterioration. While on the other hand, when we looked at the moderate or mild to moderate developmental encephalopathy, there was more of a consensus that there is at least modest improvement, if not significant improvement. In the self-limited infantile epilepsy, again, more consensus about significant improvement. Same for the neurodevelopmental disorders with epilepsy. And then again, with the last column does not apply, given that in these patients, we do not expect to see epilepsy. And moving on to the next part of the table regarding the development, in the area of severe developmental epileptic encephalopathy, there was quite a bit of a consensus that there was no significant improvement or modest improvement. However, the respondents ranged between anywhere from the possibility of severe deterioration to some limited change or limited improvement.
All right. So so much to unpack there. I hope that people listening could see just the amount of time and energy that went into all of this, because we really tried to dig in and delve and think about what it is truly that our families are experiencing. You know, we meet with families almost every week over Zoom, and we're hearing about all of these things that are challenging, that are causing issues, that are impacting quality of life, and they're not currently being measured and seen and published in a way that allows us to understand that they're really happening and at what level. So, you know, I thought it was really great that there's clear data again and again that there are non-seizure impacts that are a high priority for families to improve quality of life. And this is the baseline for us, right? This is what we know now. This is what we can have built consensus on now, but it will only continue to grow. And this will help us, as you know, several people have said so far, that we need to learn more. And that's going to help drive the kind of research that we prioritize for the Alliance and the SCN8A community moving forward. I don't know, Scott, you see a lot of 8A kids. You know, what did you think about the consensus
I think
comorbidities? Yeah.
Yeah, I think it's super useful, not just for me, but especially for maybe a person again who's maybe never seen this at all, or has only seen a few cases. What we were able to agree on to be able to say there are 17 related clinical features other than seizures that may occur in people with these conditions is a really useful starting point, because generally the conversation is going to center a lot of time around the epilepsy, right? But families want to know, like, what else could happen? What else do I need to keep an eye out for? What do I need to be looking for, right? And if you have no experience with that, I don't know, you can say developmental delay and, a few other things, and you might not really be cognizant of the scope of all the other issues that could arise that you need to be thinking about every time you see that patient and looking for maybe a heightened awareness for it. So I think that's really useful. I think super useful that within the severe DEE, where the most experience is, we were able to agree that for 15 out of 17 of those things are present in greater than 50% of the people that present with that phenotype. And among those, many times there may be some improvement, but a lot of times there's limited change and sometimes worsening, just to give an idea of where we're starting from. At the same time, as we said before, this identified a lot of areas that we simply don't have the answer. There are some methods out there where maybe the answers reside. Maybe they reside in the registry data. Maybe they reside in a registry to be determined later, a study to be determined later. I don't know, but at least it identified where some gaps are that we can continue to address, so that we can continue to improve upon this. But I think it shines a light on a section of epileptic encephalopathies in general that doesn't get talked about enough, which is something other than the seizures.
Yeah, absolutely. And I think that, it's amazing the consensus that we've heard about so far. And I'm really excited about this next section, which is talking about consensus on what families who have children with SCN8A should expect from their healthcare providers in terms of the kind of care that they receive. And it's really been distilled down into 8 distinct areas of expectation that that families should really hold their providers accountable for. So here's my conversation with 2 experienced, amazing SCN8A moms and leaders who were part of the core panel, Tammy and Kayla. I'm so thrilled that we're here with Kayla and Tammy talking about what families should expect from their SCN8A clinicians. And this is what was built as consensus across all of the clinicians and clinicians and families who were involved in this process about, what really families have the right to expect when they're seeing a clinician who's treating their child that has SCN8A. So to begin with, let's just quickly hear from who everybody is. My name is Gabi Conacher, and I think you'll hear from me, but let's hear from Tammy.
My name is Tammy Koistra. I'm mom to Liam. He's 9.5.
My name is Kayla Waldrop. I'm mom to McKinley. She is 4.5 years old.
Terrific. Well, thank you both for joining me, and thank you both as core panel members on this process. So both of you put a great chunk of time into helping us do this process, meeting on a regular basis with clinicians to talk about, what we know about SCN8A and the kinds of things we want to build a consensus around. So you all played a key role in working with these clinicians around the world and other families to really build this consensus. So thank you both for your time there. And for joining me today to talk a little bit more about what families should expect. The first thing that there was agreement on is that clinicians should really have a sense that there is a wide range of diversity within SCN8A, including the 5 identified phenotypes in this consensus process. I mean, why do you guys think that's important?
Treatment. I feel like it's a big part in how you're going to treat your child and what to expect. So this would be drug resistant, if you might figure it out on the first try, or if it might take multiple meds.
We know SCN8A is even more diverse than that, right, Tammy?
Well, yeah, I mean, like with Liam, we know that he's a gain of function and he has seizures right away, but then you have children who get seizures later on in life or some that don't have seizures. So the treatment of these children are all different.
SCN8A is probably one of the most common neurodevelopmental disorders in terms of incidence. And what we're learning is that as more and more people get diagnosed, we're learning more about different kinds of SCN8A, right? Like we just had a family who posted on our Facebook page this week about her son who had onset of seizures at 27 years old. So that is not a phenotype that is identified here, but we know the field is always changing. And for now, we have consensus on these 5 phenotypes that do exist and a better understanding of how to treat them, as you've heard from some of these other presentations. Okay, we also have consensus that clinicians should really follow the research on SCN8A, right? Families should expect that if they are treating a child who has SCN8A, that they should be willing to do some research and better understand the disorder. What do you guys think about that? Any thoughts on why that's important?
And if I expect it in whoever our doctors are.
Yeah, if I take my child to a doctor, I would prefer they be, educated in SCN8A or at least willing to want to learn. That's a good start, right?
Yeah, absolutely. And the reality is that with a rare disease like SCN8A, right, there's less than 1,000 cases that have been identified to date around the world. Not everybody is going to be able to go to see a clinician that knows SCN8A. So finding somebody who's willing to learn, and frankly, the next one, which is listen to families, we bring an incredible amount of knowledge to the table as well, as families within our community. And I think that next one, that a clinician should really listen to families and value the input that we have on the priorities of care for our children. Right, McKinley? Yeah.
She sounds like she's saying mom.
She's shy.
Yeah, right. I mean, so we've seen this come up a lot. You know, we hear from families every week who are struggling with clinicians who are not listening to them, or about what their priorities for care are. You know, why is this so critically important, Tammy, do you think, to have a clinician that listens to you?
Because if they're not listening, then you're not being heard. You're not going to get anywhere without that. So
Yeah.
hopefully, I mean, I have changed doctors because of this.
When you have clear priorities for how you want McKinley to be cared for, you know, how do you communicate that with your clinician, and what do you do if they don't listen?
Well, if they don't listen, I find a new one. We're on our third, and I'm thankful that he is very open-minded and listens. I feel like, a different approach than a lot of people. Knowing that she's on the more severe end, I'm not as willing to try and fail as many things. I'm just kind of looking for quality of life and trying to find what reduces her seizures enough to still let her be happy and smile and interact throughout the day. And some doctors weren't as on that same page as me. And so, it's a hard balance to figure out. And then I feel like just being the caregiver at home, I'm with her literally 24/7 since the day I had her. So for 4.5 years, like no one else is around. I feel like I notice a lot of funny little things that trigger seizures. And so I also need them to maybe not think I'm bonkers when I say that, like that dairy and diet changes have actually helped so much, where early on dairy was the big trigger for her. And so just need to be able to feel like I can express those things without any judgment, and just really important to feel her to listen to.
We know that SCN8A is complex, requires a lot of care from a lot of different providers. And so there was consensus that clinicians should provide referrals to early intervention specialists and complex care as appropriate, and hopefully as soon as possible, right? We know that things like speech and language processing and developmental delays are fairly common amongst those, even across phenotypes with SCN8A, and getting early access to that really matters. I mean, Tammy, you've been getting a lot of services. What is that?
We've had intervention since about 4 months old. You know, we had physical therapy, OT, the school would bring that in also, and then we had it out of the house also. But I mean, the earlier you can intervene, the more the child may develop and, be able to do the things that you want them to do. But yeah, we started on really early.
I hope you don't mind if I say this, but I mean, you're pretty open about the struggles that Liam has with GI issues, and you've struggled to get those referrals and get things approved and find, so.
Yeah, I mean, we actually struggled. We actually ended up in the hospital because he started vomiting his formula up, so, which included his seizure medications. So we did get the referrals, and we never did get some of the testing that we needed to have done.
What about for you, Kayla, in terms of accessing specialists and
we used early intervention in the beginning, and we would do feeding therapy, speech therapy, and I think for me, in a lot of ways, I almost kind of had like a head start in that area plus just my background in healthcare. But I do feel like it's so important to go and at least learn. Like, I'm a first-time mom. McKinley was my first child. So there was a lot of things that I was just totally unfamiliar with, like what normal babies do. So to me, the things my child were doing seems normal. So whenever someone's like, no, actually, like she should be holding her head up and doing ABC, those are really important things that I kind of learned along the way that I didn't notice.
So one of the other things that's really important that there was consensus on that clinicians really understand is that they should be open to discussing SUDEP and bring up the topic with families and read the room, right? Like you bring it up, it's your responsibility as a clinician to mention that this is a risk. And then some families will say, don't want to hear about it. And that's their choice. And others will say, tell me more. I want to know what I can do. And it opens up that door for conversations. And I know, Tammy, you have a lot of conversations with families about these kinds of risks. Why do you think this is important to families?
Well, for me, I didn't know. Well, it was in my paperwork, the paperwork that you get when you're in shock and you put it away and you don't read it again. And it probably was mentioned to me, but I just probably didn't know what SUDEP meant, right? Mm-hmm. But I never heard or learned what it was until he was about 2 years old. So I thought to myself, if something had happened, I would have wanted to be prepared. Like for myself, I would have wanted to use a seizure monitor. It's everybody's choice what they do, but for me, I would have wanted to know if something was going on. So I think it's really important to have the conversation with children who have epilepsy. Anybody that has seizures is at risk.
One of the other things that came up is that that there should be this ability and willingness to collaborate across specialists, right? We all see GI and neuro and PT and OT and speech and all of these different caregivers. And oftentimes decisions are not just affecting one system and need to be, or there's new medications being introduced. Does that conflict with, or is that contraindicated against other medications that are in play? And so this was a really important area of consensus. And Kayla, I wonder what your thoughts are about care coordination and making sure that doctors are able to talk to each other.
I mean, my thoughts on it are, I wish it was better, at least where I am. I feel like that responsibility tends to fall on the caregiver for the most part, and it's a lot to take in. It would do it. I don't know if that's the right word to use. I don't want to say burden, but it would ease a lot of the stresses if you could count on your medical professionals to collaborate together and to pay attention to the med list on, okay, if we change this med, is it going to affect any of these other meds? Is it going to maybe increase or decrease like the concentration of it? And
one of the things that the International SCN8A Alliance has been working to really promote more within our community is the understanding of the need for a seizure action plan. And we got consensus through this process that clinicians really should take on a leadership role or a partnership role in helping every family have a seizure action plan. Now, anyone who has seizures or who's at risk of having seizures is the consensus should work with a clinician to have a seizure action plan, which essentially outlines what to do in case of seizure emergencies, right? Do you all have any thoughts on seizure action plans and how they can be of use?
Just that I think they are really important to have in place.
Yeah.
Especially in school, if, there's got to be, people trained to be able to take care of your child and call the right people and do the right things, and get the right steps in place, because, it's a matter of time with these seizures. You want to get an ambulance called if it needs to be done. At home, Liam doesn't go to school, but with the girls here, if he has a tonic-clonic, he gets rescue meds right away. If he doesn't and he has a small seizure that's not a tonic-clonic, we don't. But they always are, if I'm not available, calling me or contacting me right away. Mm-hmm. And we have this thing where if he goes into a seizure and it's not stopping, you call 911. So we have that, put in order here, but.
And I think that's so important, is that it empowers the people who are caring for our children to better understand how to help them in case of emergencies. And one of the final areas of consensus about what SCN8A caregivers should expect from their clinicians is that they help develop and implement and carry out a transition plan, moving from pediatrics to adult neurologists. And we know this is incredibly important because of the reality is that there are not a lot of adult neurologists who are familiar with rare disorders like SCN8A. So I think this is an incredibly important one for families to feel empowered to say, I know this transition is coming. I would like you to help me make this as smooth as possible. None of us on the call today have been through that, but we know of others who have and how important that is. Have you heard any stories or heard any insights about the power of having a smooth transition? Either of you?
I haven't, but I can say that that is a terrifying thought, just as a parent, to have to completely switch everything over in 18 years to someone else. And it would be really hard. So it would be nice for that to go as smooth as possible.
Mm-hmm.
I mean, I've experienced it with my daughter with her type 1 diabetes. Yeah. It was way different switching from an endocrinologist that dealt with her whole life, and then all of a sudden we're at a doctor that knows nothing about her. So, I mean, I've experienced it in that way, but I haven't experienced it with Liam yet.
I think it's so powerful to, for you all as caregivers and advocates to have been a part of this process and to share your insights, go through this whole process, but also today in this session to help families better understand what they really should understand they have the right to and have the right to expect from their clinicians. Is there anything else either of you wants to say about this process or about what we went through today?
I'm just really excited that it's happening. And I remember when we got our diagnosis, and the first thing I did was go to Google. We were actually inpatient, and we had, it was the first day she started having infantile spasms. So we were hospitalized. I got the genetic results that same day. And so it's nice to have that reason why, but then you Google it and you find like nothing. So I'm excited there's going to be this like quick and dirty rundown on things for clinicians, but also us.
Yeah, I'm excited too. When we got our diagnosis, he was 2 years old. So for 2 years, we kind of were flying, blinded, right? And then I get this diagnosis, and then I think to myself, we Googled, we did the same thing, and it was really scary. So I'm just hoping that people don't feel so blinded like I did. When we first got the diagnosis, it was so rare that there wasn't a whole lot of information. So, and I imagine as we keep researching, we're going to get new things coming up, and, new ideas and new treatments, and hopefully a cure one day,
Yeah, definitely working towards that. Well, thank you both for joining, and so grateful to get to work with and be friends with such amazingly strong and smart women who are leaders in the lives of their children and our community. So thank you for everything that you've done and continue to do.
Thank you.
Thank you.
All right. Well, so that gets us through all of our videos. You did it. You survived. You made it through. Just a huge thank you to all of those people who recorded those sessions with us to make them available here for us. But Scott, any thoughts on that? You're a provider. Did those seem reasonable to you?
Well, yeah, they're reasonable. I mean, if you'll recall when we talked about creating those consensus questions, I was one of the people that said, do we honestly need consensus on these subjects? I mean, isn't that just how it should be? But I guess not. I guess that's not how it is. So I do see the value there. So I'm glad that glad we're able to do that. That's another piece. That's another piece we have. And that was the easiest area, I think, for the respondents to reach consensus were on those questions. So that's at least a good sign as well. Yeah, so I mean, overall, really good. I hope everyone gained a lot from what they saw. The papers will be out, we certainly hope, in the very, very, very near future, because there's a lot more to dig in than what we kind of went over, during this kind of summary. But I hope what you see is that the value of this consensus project. There are, more and more people are going to get a diagnosis of SCN8A. More and more people are getting genetic testing, which may have variants in SCN8A, where it's important for people to understand what it looks like to decide if those variants are actually the cause or not. And I hope that these two documents that we have created from this project really are an accelerator. So they accelerate people to getting to the right diagnosis. They accelerate them to getting to the best care. They accelerate them towards the best outcomes. As you said, we can't all go to, it wasn't easy to find people to be on the panel to start with that had experience, right? And everybody can't go to those people. So this is a document to really help hopefully get everybody on a good foundation to begin the care of these conditions, no matter where you are. So I think it's very exciting that we were able to complete it.
Yeah. And, I just can't wait to see how this gets put to use. And we're going to do a lot more to talk about that. But right now, what we're going to do is we're going to invite in some of our core panel members to join us for the Q&A session. We have a number of questions that came in the chat. And so I am just looking right now. Anybody, all of our core panelists that I see in here are getting invitations to join us on camera, which you're welcome to do if you're up for it. No pressure if you don't want to. I know some people are traveling or doing other things. So just an opportunity to pop in and be with us as we're talking here. So I'm going to start with, there's a couple of questions coming in about, let's see, I'm going to go to the beginning for the first ones that came in. One question about how frequently should they do MRIs and EEGs? I think this is a really interesting question. We don't have consensus on this, so we're not really going to be answering from that point of view. But I mean, yeah, I don't know if you have advice for how people should manage those conversations with their clinicians.
I'll tackle it right now while we get the rest of the panel on, and the other panel can jump in. I tell you, just in general, from an MRI and EEG standpoint across epilepsy, this is not specific to 8A. It is what is going on and what are you going to do with the data that you have, right? So people ask me a lot of time, are we going to get a follow-up? Are we going to get a follow-up EEG? I would say, well, what are we going to do with the information? Are we having events that we are unsure if they are seizures or not? In which case, capturing them on an EEG will clarify it to guide treatment. Are we seeing a change in the patient, some decline in some way or some other change that we'd want to look at the EEG to see if it's changed somehow and that's the cause? Maybe we've seen improvement. We want to think about reducing some medications. And so we want to see, does the EEG support that clinical finding to do that? Same goes for the MRI, right? Is something changed in the characteristic of the seizures or the characteristic of the exam or the characteristic of the daily baseline status that for some reason we have reason to believe there's something that's changed on the MRI that we're going to do something about? Because we have to remember that in a lot of the cases we're talking about here, if we're going to do an MRI, we're doing sedation. And while the risk of sedation is low, it's still a risk. And is it really necessary? Is it going to change the course of treatment? If it's not going to change the course of treatment, then it's not a path we necessarily need to go down. So there's not some routine recipe for this is how often to get an EEG, this is how often to get an MRI, in my opinion.
Yeah. And others, other core panel members, hopefully you are you're able to come on. You'll only be on camera if you select to be, but great to have you all with us. Bradley pointed out that there seems to be a gap in patients in the 30 to 50-year-old cohort. Their daughter was recently diagnosed at age 30. And I think it's so I think this is going to be a larger cohort coming in right now as genetic testing becomes more available. It is a bit of a gap. I mean, Elena, you actually have one of the oldest patients with SCN8A, I think in their 60s, right? So we just found out about a 27-year-old that got, so I think they're out there. We know they're out there. It's just a matter of getting access to genetic testing and really finding them and obviously bringing them into our community. And I think there's more education that we can do on our part around with clinicians, adult clinicians, who are not as familiar with that. Mark, you're nodding your head. Tell us what you think about that. Sorry, you nod your head, you make yourself liable to get called on.
Yeah, I think the access piece is something that is still difficult, right? The prompt and timely access to genetic testing, because certainly some of it depends upon where you live, some of it depends upon the familiarity of your clinician with the need for testing, and then some also depends on the age of the patient, right? The reality is in the adult neurology world, there is still not the same level of awareness about the importance of genetic testing that there is in the pediatric world. And I think that's starting to change, not necessarily at the pace that I would hope for, but I think it's starting to change. And I think the more we can sort of advocate, to try to get that sort of broader access for really anybody with unexplained epilepsy, the better.
Yeah. Anyone else want to weigh in on that?
I will comment on a little bit because this is definitely an issue. We are aware about the difference, the local difference in access to genetic testing for sure. But there is another barrier because I'm expecting a bias testing towards the patient having a worse phenotype. So I'm pretty sure we did it in Denmark. We are quite lucky. So we are able to test pretty much. And in our cohort of subjects with developmental encephalopathy, we found up to 30% of genetic abnormalities, including perhaps some SCN8A, which are not that frequent as we expected, to be honest. But we are sure that we will never test the benign phenotype. And that all my research has been based on the subdivision of phenotypes. So I'm pretty sure that we need to subclassify and for finding out some reliable information. So I'm expecting to get information for the worst part of the spectrum, and for the benign one, we need to wait probably.
Mm-hmm.
But
I'll state the obvious. From an evolutionary point of view, there's no reason to believe that SCN8A hasn't been around in humans forever. And maybe there's some increase in mutation rate. We don't know. But for the most part, you can think about all the people before, and I think about this a lot because Shay was the first, all the kids and all the adults and all the people that came before us who had SCN8A that had no idea. Mm-hmm. So we're living in a new time. And welcome to genetic testing, and that's going to get better and better.
Yeah, absolutely.
Probably the one not test and they do not have any special needing as either, but yeah.
And I think the spectrum of who we're seeing diagnosed is changing so much too, right? Now people without seizures who are getting diagnosed. And I'm really excited that this consensus has some guidance for those families too, because we get a lot of families who come in, and Tammy, who's one of our ambassadors, she talks to so many families that come in. And Tammy, what is your, how do you feel about the ability of this consensus to answer some of the questions that you hear families talking about when they come in? Because you talk to a lot of families.
Like with the more severe children who are having seizures right away, it's like we're pinpointing a medication that might work sooner, and quicker, and, it helps take the strain off some of the families. And then having information, like being able to say, hey, this is, what you should possibly do, or contact this person, or go to this doctor, because I send people to Texas Hospital all the time, but
Sorry,
it's just,
Scott, you're getting overrun.
So it's just helpful. It's helpful, you know, and like I said, I didn't have that. So just having somebody to like help me out in the beginning when I was like sitting in a corner crying somewhere, you know, thinking that my world was over, you know.
Well, you do that now when you counsel all these families that come in, and hopefully these resources will help as well. Crystal, we had a question about what is meant by orthopedic issues that, you know, when we were talking about the comorbidities, does that, they say, is it bone density? Is it stunted growth? Is it fractures? What do you think is a part of that?
I think it's several issues, and I think that they can be either directly or indirectly related to the encephalopathy or the basically the dysfunction of the brain, meaning that a lot of children might end up having low tone or high tone, and that on its own is going to really affect the joint movement and sometimes create additional contractures. And unfortunately, when a child is not really bearing weight, trying to walk, being able to go out and sit in the sun, there is definitely a decrease in bone density and an increased risk of fracture. And I think one of the other things too is that when a child is nonverbal, they can't really tell us what hurts or if we are overdoing something, or be it on purpose via you know, via physical therapy, or be it any general movements. And then additional, more specific issues that are more related to the tone include scoliosis. So that is a common thing, and there are some reports in the literature. I think that's highly related to tone. So I think in my own practice, again, a little bit outside of the consensus, but in my own practice, I tend to send all of my patients for at least a baseline evaluation to decide how often we need to look for hip dysplasia or scoliosis, looking for vitamin D, or even if needed, bone density studies.
Mm-hmm. Yeah, thanks. And we're learning, I mean, I think more anecdotally, we're learning about a lot of these things about, you know, that are not in the literature, but families are telling us, right? The scoliosis, the bone fractures, you know, all of those kinds of challenges. So
actually, this information are in the literature is something that we should focus on. I mean, and there are also in the registry, this is important just to spread. I mean, the biggest, I mean, values of this consensus is that something which is considered quite, I mean, achieved as a knowledge among a restricted group of experts by chance, because we are dealing with that, now is becoming, I mean, more evident for a larger population, I mean, a larger cohort of experts, both from the family side, especially from the physician side. So I think this is get access to many more people to the restricted knowledge, and even, I mean, stimulated implementation for that, which is, I mean, I'm extremely grateful for, because actually something which was difficult to convince people of now seems to be obvious and accepted, which is the first step to move further to new knowledge and to better, I mean, standard of cares. But yeah, that's something I heard it many times, that they say, okay, man, but my physician said it was not relevant, it was not obvious, but something are black and white on paper. So I think this thing has to be all the physician taking care of our children as SCN8A needs to know, needs to accept as something which is not a speculation, it's not an opinion, it's been already proved.
Right. Yeah, absolutely. We're getting some questions around genetics and inheritance. So, you know, one is, you know, do you recommend that siblings of children with SCN8A get genetic testing? And, you know, we don't really have consensus in here about this. We're kind of veering away from the consensus here because people have a lot of questions that are not in there. So I think as we're answering, please recognize that these are not part of the consensus. But, you know, there's certainly people, we're talking a little bit. I mean, Michael, you're a geneticist by training, so maybe we'll throw this one at you.
Well, I mean, it kind of correlates with the finding more families with milder symptoms or loss of function. And in that case, there's going to be more inheritance. If you think about it, again, from an evolutionary point of view, on the DEE side, you know, those people aren't generally going to grow up and have kids. So it's generally not going to be inherited. You'll find more de novo mutations. And for those on the milder side, and the selfie and the mild and some of the loss of function, we have many cases of inheritance. And that just makes sense from an evolutionary point of view. So I think it really will depend on your situation. If you have access to genetic testing for your family, take it. It's very valuable to have a pedigree and to know who has a variant and who doesn't, and what your chances are of passing on as a carrier or as somebody who's very mildly affected to the next generation, to be prepared for seeing a clinician right away saying you have SCN8A, and then all the things that now tie into the guidelines come into play.
Mm-hmm.
I would like to add something, and I'll tie it back to the consensus, which is, you know, who do you need to see? You need to see someone who understands your disorder and is amenable to do some research on it. And I think part of that does include learning more about the genetics and how it works and how to counsel, because I think counseling about the risk of recurrence is another important aspect, even if both parents are tested and they test negative, to keep that even very, very small possibility of what we call mosaic, meaning some of the cells in one of the parents do have that genetic variant, but it does not show up in the blood. And that with every child that has exactly the same risk. So the risk of recurrence in some families, you know, is not zero. And I think that's something that the neurologists who are seeing those patients, maybe pairing up with genetic counselors, should be able to discuss right off the bat.
Mm-hmm. Madeline, I'm going to throw this one at you. There's somebody who's asking about the possibility of ASO treatments in SCN8A. They're asking about a specific mutation, but I'm not sure we're really at a point where we have, you know, those figured out yet. But maybe tell a little bit about your background, and yeah, is now okay time to answer? You good?
Yeah, sorry, I muted myself and my husband was talking to me. So yeah, I'm Madeline Oden. I'm a mom to a child with SCN8A, Margot, and also a scientist and researcher who has my lab at Tufts University, and we're doing more and more research on SCN8A and ASOs. It's definitely a really interesting prospect for neurodevelopmental disorders as a whole, and I think there's more and more genes that are being targeted for ASOs to, you know, use as new treatments. And, you know, just a few weeks there, last week, there was some great data that came out on SCN1A for Dravet, which is, you know, a different disorder and different approach, but, you know, showing that using an ASO, you can get good effects on seizures and also behavioral behavioral features. So that's really exciting to see that, you know, with these genes, you can use ASOs and have positive effects on seizures and development. But for SCN8A, it's quite complicated. SCN8A is a really important gene for the brain, and manipulating it and the amount of it can be really tricky, because if we have too much, we have seizures. If we have too little, we have, you know, these loss of function disorders. And so it's more challenging than with other genes. And so that's made some companies shy away from, you know, targeting SCN8A for an ASO. So it's not straightforward, but, you know, I think there's a lot more approaches that are being developed to kind of use these types of genetic therapies. And so I think, you know, there's a lot to be hopeful for, but right now, you know, there's nothing really specific on the horizon, but some companies are thinking about it and trying to develop better approaches to use ASOs for SCN8A.
Yeah, thanks so much, Madeline. There's a question about how are variants classified as gain of function and loss of function? How does that happen, and how can people find out if their mutation is gain of function or loss of function? I'll start by maybe Elena, I know you did a great job explaining in your chat a little bit about gain of function and loss of function. And maybe you can share a little bit about how that's determined.
Yeah. What we do normally, based on our experience, is to merge the clinics, which I believe, I'm a clinician, so actually I'm definitely biased, but the clinics tell us pretty much about the possibility of gain versus loss of function. And the prediction tools, which are so now we are in our database. We have 750 cases, and we have a good mismatch. The problem is that we have some epilepsy type, especially the phenotype in general, which is pretty well clear-cut. So we are almost sure about the functional effect. This is behind this activity. So we can easily, with some, accuracy in taking, the data, the analysis, and then we can easily predict how to manage and also the development. And there is still a gray zone in between of patients which are really, somehow tricky to assess. And normally they are the one having epilepsy in a milder, the milder severity, which can belong either to the gain of function, to the loss of function. The severe one is a gain of function, the very benign one is a gain of function, the loss of function are the generalized, which is easily distinguishable, and they're also without epilepsy. But in the intermediate phenotype, we still are struggling, and now we are working intensively on that. We're working in 2 years for the electroclinical details and possibly also some parallel evaluation. We are working on that. We have some achievements, but fortunately, it is not the larger cohort, but still for the children, the patient belonging to that is still, the single children is still an issue. It's still an issue because also the response to treatment is not obviously reflecting the effect of the variant, which sometimes can be complex.
Yeah, Michael, do you want to weigh in on this? I know. Oh, sorry, I didn't mean to.
I mean,
I talk about this a lot. Yeah.
I agree with everything Elena said, and I think she's in a really great position to look more in detail at these intermediate types. I think the practical question is, on loss of function, you don't want to treat with a sodium channel blocker. So what about these intermediate cases where they're mixed gain loss? If the phenotype is mixed and gained loss as well, what do we know about treatment with sodium channel blockers? Because I know a lot of families who have these situations are on sodium channel blockers, and it doesn't seem to hurt. Sometimes it helps. So what do we know about that?
Exactly. This is exactly the issue, because I strongly believe that for this intermediate case, it is not by chance they are ambiguous. They are ambiguous because their background is ambiguous. So this is exactly the issue. So this is why I really trust, we keep working on the functional side, but I really trust the clinics because I believe evidence. And that is what is the evidence. And this is why I'm trying to find out as many details as possible, permitting us to go, toward one direction instead of the other one, because this is the evidence. The evidence is the result of a combination of factors, including the combined effect of the variant, which is definitely possibly the case. So I think that for these children, as long as we do not have a concrete solution, because our brain is complex, we need to just rely on facts, on the clinical facts, and the biomarker is valuable as well. I believe pretty much on EEG findings, which are helping me pretty much in just taking a decision. Everything is valuable if you measure in the proper way. But for some children, as a group, somehow it's difficult to discriminate, but for concrete single patient, maybe really an issue. For them, it's 100%.
Yeah, I'd just like to throw in that some variants have mostly a gain of function, but have also the variant I'm studying in my mouse model has mostly gain of function properties, N1768D, but it has low peak current. And if I transfer that mutation from a BLAC6 background to a C3H background, I can make it a loss of function. So this definitely speaks to the idea that circuitries matters, and humans are diverse, and sometimes our genetic background will modify a variant to make it on a circuitry that is going to be more of an absence seizure, a different seizure type. And so this, we don't understand much about at all. We need more people studying circuitry to really understand this. And then the drug effects, who knows? We need to, we're into future territory here.
Definitely. This is the problem. And also we published with Holger Lercher a paper, which the same variant tested on ovocytes, give them gain of function effect, the opposite, right? Loss of function effect on in neural cells gain of function. So even if the functional testing is the gold standard, it's not always 100% reliable as well. So we know that we do not know always everything. So we need just to keep pushing.
Well, we are unfortunately running low on time. I think maybe we should do this again. This is really exciting and powerful to continue these conversations, and we certainly will. With some of the upcoming work of the Alliance, we're very excited about some of the meetings that we're planning in the coming months that are going to continue these conversations amongst caregivers and clinicians and researchers and all of those things. So I want to thank all of our core panelists for joining us on screen. Thank you so much for all of your work in this process and for joining us today to showcase some of what we've been learning about through this consensus process. I want to just give a shout out to everybody who's given a ton of questions. There were a lot of questions in the chat that we didn't get to. Please feel free to just email us if you have follow-up questions that we weren't able to get to today. I'm going to put my email in the chat. Use it anytime you have questions or concerns or thoughts. That's what we're here for. Okay, so I think we're going to move on to looking at some of our final elements here. So what is next for us in this process? Well, we're very excited that right now you can go to our website and find a lot of this information. It is a work in progress. We have 2 staff members who have been working furiously to try to get this up, Charles Anderson and Kelly, who I don't think she's on today, but these are 2 people who have been working with us tirelessly to try to make this information accessible and available to all of you. So please, you can scan that QR code there, or Charles will put it in the chat, the direct link to our website. You can see that up in the blue at the very top, it says treatment guidelines. You'll be able to find a ton of information there. So please check it out, refer to it, send it to people who you think should see it, should know. This is the lay version of it. Of course, the full papers will be out in the next few weeks, we hope. Charles, can you send that message to all participants? That's just the panelists. Thanks. And let's see. All right, next slide, please. Okay. So we are going to continue this dissemination. It doesn't say it here, but we are now working with our SCN8A Global Alliance partners. You can see them here in the bottom right. These are all of our global partners who we work with around the world to tackle SCN8A. And we are working with them to plan sessions around the world. Charles, you're showing us your computer screen. So we are we're planning sessions. We have a session in Spain in May. We're going to be talking at Boston Children's and Harvard in May. We are going to be all over the world. There's going to be sessions in Italy, Portugal, hopefully France. We're really working on covering as much ground as possible. If you have somebody that you think or a location where you'd like to see this more information shared, reach out and we will work with you to do that. In the meantime, please, if you're a family on the left, join this private caregiver group where we share a lot of opportunities for research and announcements. And on the right, if you are somebody who is not a caregiver, please follow our public Facebook page where we'll be making a lot of announcements about more opportunities to be sharing this information. So follow along there. All right, next slide. Okay. I mentioned that we have near weekly meetings that are hosted by myself and Dr. Hammer, where we just love to share information and connect. And we do this in multiple languages. We're going to be having a session with in French next month, I hope. We do them in Dutch, Italian, Spanish, Japanese, all sorts of languages. So you can be on the lookout there. All right, next slide. Okay, so now we're getting more into the big chunks that we want to take a bite out of here, which is really looking at how do we continue to tackle what was not found here. And we are incredibly excited about a research roadmap meeting that we are planning in August. This is being planned by myself and Madeline Uden, who you heard from, and Jayetta. We're really coordinating on pulling this together. And this is going to be a meeting where we have caregivers and pharmaceutical partners and researchers and doctors all sitting around the table and saying, what is standing in the way of getting us closer to better treatments and cures for SCN8A? And then as a global community, we're doing this meeting in partnership with our Global Alliance partners, who you saw on the last, on that earlier screen. So this is Italy, France, Portugal, Netherlands, Spain, China, Brazil, all over the world. These are caregiver-run organizations that are working together to really build out this map of what we need to do to get better information and quality of life and research done to get us closer to cures. And then from that, we will be prioritizing as a global community what research we need to fund to get us closer to those answers. So this is really, we're moving our way up this tall mountain, and this is just another step along the way. And we're really, really excited about this meeting to help us kind of really figure out what the most important things are to tackle. And we're only going to be able to do that with all of you family members weighing in the next week or so. We're going to be sharing a survey where we're going to ask every family to share what their priorities for research are, so that as we are sitting in that room, and there will be a number of caregivers in that room representing our community, we can all be speaking to what matters most to our families. That's how we're going to drive forward our next steps in research. It's going to be in with the families in mind and what we want and what we need. All right, next slide. Okay, this is small because there were so many people who were involved here. I wanted to give a huge shout out to every person who was a part of this. Doesn't even have all the people who were involved in some other elements, but the leadership team was Scott, Elaine Worrell, Jayetta Hecker, and Maya. And I just have to pause and give a huge shout out to Jayetta and Maya, who really led the analysis of this intense process, digging in. And Maya Shia, who's currently in med school up at Columbia and has continued to work with us while she's in the depths of that process to pull this together. Just could never have done it without her. And Jayetta, who just really learned the process and really became a student of the modified Delphi to make this happen. So incredibly grateful for their leadership. And Scott, for all the time you put in that you're now going to gain back, which is exciting, right? You saw a number of the core, and just remember to keep your phone. I have you on speed dial for when we do the consensus again. So in a few years, watch out. You saw a number of these folks here: Christelle Ashkar, Christine Cuquier in Spain, Seth DeVries, Elizabeth Donner, Mark Fitzgerald, Elena Gardella, Michael Hammer, Anaita Hegde from India, Chenhui Hu from China, Mitsuhiro Kato from Japan, Tian Luo from China, John Schreiber from Children's National, Yi Wang from China as well, and the families, Tammy, Madeline, Kayla, Tyler, and Dennis. And And then clinician reviewers, these were the people that reviewed and voted on whether what we were saying made sense or not. An incredible group of respected clinicians around the world. And then our caregiver reviewers who also helped us figure out, are we on the right track? Are we asking the right questions? What are we missing? It's incredible. I mean, I come to the point, I don't cry very often, but I see this and I think it's incredible what we were able to pull off. And this is all with people who are volunteering their time and said, yes, I want to be a part of it. Yes, I want to make a difference. Yes, I want to help build a better tomorrow for those who come after us, and do our best to try to build better, more knowledge from for our kids now, to try to improve quality of life as much as possible. And just really grateful to all of you for your time and dedication and passion for making the world a better place for our SCN8A families. All right, one last slide, I think. Charles, last slide, I think. Okay. So, the International SCN8A Alliance financed this process, which somehow, we pulled it together, we scraped it together to really make this happen, because we saw how critical it was. There was limited funding for the process itself, but we are so incredibly grateful that some of our SCN8A Global Alliance partners chipped in and said, hey, we want to help be a part of this and contribute. So SCN8A Italy, SCN8A Netherlands, and SCN8A UK and Ireland, thank you to those partners for contributing. And we're really thrilled that we have some financial support from Neurocrine and Longboard to help us do the dissemination of these findings, because our intention is that we want to reach every corner of the world with this information. We want to pass it on in as many countries to as many institutions as we possibly can. So if you're interested in being a part of that, please reach out to us and help us plan these sessions. We already, as I mentioned, have sessions around the globe planned, and the idea there is to share this information not only with clinicians, and not just neurologists, not just epileptologists, but therapists and endocrinologists and GI specialists, and all sorts of specialists who work with those living with SCN8A, so they can better understand how to care and treat for our families and our children. But also to families. We are planning some resources to translate this information into lay language. The publications will be very scientific, and we hope that we're going to translate these resources for families into many global languages, so that they can be highly accessible to use as advocacy resources. And you can take these to your doctor and say, this is what the latest findings are. Would you please read this? And if they say they're not going to read it, then you move on to another clinician as fast as you can, right? But that's really our hope, is to make this information as accessible as possible to those families and clinicians. You can find, as I mentioned, on our website right now. There's a lot of this information. It's a work in progress that we're trying to build out as much as we can, but just about everything you heard today is on our website, and you can see it there. As soon as these articles are published, we will make them public and share them widely with anyone and everyone. We're actually paying to make sure that these are open access, meaning that nobody has to pay for these articles behind a firewall. So that's our hope. That's our plan. Get this information out there as much as possible, and ensure that this information is out there for anyone and everyone who needs it. Any final thoughts, Scott, before we sign off here?
Nothing more than congratulations on getting this achieved. And I would tell you and the rest of the people to go catch up on some rest. But since we haven't cured SCN8A, I don't suppose you're going to probably do that. So good job.
There's no time for that. Thank you so much, Scott. It's been such an honor and a pleasure to work with you. I know we will continue to work together, and I'm just grateful for the partnership of you and everyone who was involved in this process. So thank you all so much. As I mentioned, please reach out to my email if you have questions or want to follow up. I know we didn't get to everything, just not enough time in the day, but I'm definitely available if and when you need me. So thanks, everybody. Take care.